I'm Dr. Richard Dolly. I am a pediatric psychiatrist at Duke University Medical Center, and I am the chief of the Division of Child Development and Behavioral Health in the Department of Pediatrics. I'm a member of the Alternating Hemiplegia Clinic team here at Duke University Medical Center in the Department of Pediatric Neurology. There are a number of physicians in various subspecialties who participate on this team, and as many people know about alternating hemiplegia, there's a significant behavioral component to the disorder. And as a pediatric psychiatrist, I participate with the teams in looking at, diagnosing, and trying to help in any way I can with developmental or behavioral problems. Children with alternating hemiplegia are afflicted in many ways. One of the ways that involves me is that they often have behavioral disturbances. They clearly have developmental delays. And as a pediatric psychiatrist, I'm part of a team of physicians who take care of alternating hemiplegia children at Duke University Medical Center. I provide the expertise in behavioral management, diagnosis, and treatment. A large percentage, although not all, children with alternating hemiplegia have intellectual disability, which means that they're going to have learning problems, they're going to have communicative problems. And that's a very, very difficult thing to manage. We work with school systems, we work with counselors to try to help them through that. In addition, many of the children have something that looks very much like attention deficit hyperactivity disorder. They're very hyperactive, they're very impulsive, they don't pay attention for very long, they're very distractible. That's actually something that we can help with medically as well as with a counselor or structurally. Other problems may include things like anxiety, and we may be able to help with anxiety with both counseling and, in rare cases, medication management. As you can imagine, there is not a huge wealth of scientific literature on how to treat the alternating hemiplegia child who has behavioral disorders. So we're forced to use the medications that we use in typically developing children to the best of our ability. I would say that probably the most common behavioral disorder that we see in these children is something that looks very much like attention deficit hyperactivity disorder. In other words, the children can be very hyperactive, very intrusive, very impulsive, inattentive, and very distractible. And this clearly gets in the way of their functioning in school, their functioning in the family, their functioning socially, their functioning in the community. So just like any other child, typically developing, of course, we use the medications that are effective and FDA approved for attention deficit. Alternating hemiplegia comes with developmental delay. So the age at which children come to us, for example, as specialists with different difficulties, different problems, different challenges, are going to be very, very different from those with alternating hemiplegia. Typically, developing children may come to us with, let us say, anxiety or ADHD at an age much later than children with alternating hemiplegia. But the best we can do is apply the same scientific principles of diagnosis and the same scientific principles of treatment that we do for typically developing children. AHC is in that large category that we call a genetic developmental disability or developmental disorder. We differentiate AHC clinically from many other developmental disorders because some of the clinical problems that these children have are very, very different from other disorders. Specifically, these kids many of them have seizure disorders, and clearly, because it's called alternating hemiplegia, they have tremendous movement disorders and things like dystonia, which is an event that can cause muscular contraction in very, very uncomfortable and unpleasant ways. So we differentiate AHC from other disorders by clinical signs and clinical symptoms. We also know that it has a very different genetic etiology or genetic reason, and so we can separate it from other disorders genetically with a genetic probe. And the path or the trajectory that these children follow is very different from other developmental disorders. So in general, it is a multifactorial approach. Different clinical presentation, different genetic origin, different ages and stages of the child as they move through life. I think the most important message that we can deliver is that it takes a team to help families and children where alternating hemiplegia is the condition. Because these children are complex, the team is generally led by a pediatric neurologist, given that fundamentally this is a neurologic problem. But there are so many other team members that can contribute to the care of this child. For example, not just pediatric psychiatrists like myself for behavior, but occupational therapists, speech therapists, physical therapists, people in the field of educational psychology. So in short, the best advice that I would give any parent is, number one, have hope. Understand that it will take a team, and understand that when a team is assembled, you'll get the very best care and the very best treatment and outcome for your child.